Now our next speaker is Dr. Rana Khan Chaudhary. She is very young and talented gynecologist and fertility specialist of Mumbai. She is now working in the Ankur Fertility Center. She will speak on the ovulation induction in IUI. I would like to invite Dr. Rana Khan Chaudhary. Please, Rana, you can start.
Okay. Thank you, Dr. Anamul Haq. At the onset, I'd like to thank Dr. Anamul Haq for this opportunity and for the kind introduction. The topic given for me today is ovulation induction in IUI. We all know that ovulation induction forms a very important part of all our fertility patients. And our aim in an anovulatory patient is to have at least one follicular growth. For a lady who is ovulating, to have at least 2 to 3 follicles. And our main aim is to achieve pregnancy in the shortest amount of time without having any complications like your ovarian hyperstimulation or multiple pregnancy. Now, when we are talking about controlled ovarian hyperstimulation, in particularly relating to your IUI, my aim is to increase the number of oocytes and correct the subtle ovarian and luteal phase abnormalities which could happen in cases of endometriosis. So, ideal response would be to having 1 to 3 pre-ovulatory follicles and to have a good endometrium ecotexture wise and also thickness wise. What are the problems? Well, sometimes you could not have even a single follicle, or sometimes you could have more than 3 follicles. The lady has hyperstimulated. You could have a poor endometrium or an inadequate luteal phase. We all have been using clomiphene citrate for ages together. We generally start with a dose of 50 milligrams starting from the day 2 or day 3 of the lady's cycle and continue it for the 5 days. Then we monitor the cycle by doing folliculometry. In cases there is no response, which means that there is no dominant follicle in spite of giving this regimen, we can increase the dose of clomiphene citrate to maximum up to 150 milligrams per day, and such 6 trials can be given. Now we see that almost 60 to 70% of our patients will ovulate with this regimen, but only 30 to 40% becomes pregnant. But the main problem is the high risk of abortion with this clomiphene citrate, and also the peripheral anti-estrogenic effect because of the long time of action of clomiphene citrate. Other problems are your CC resistance and CC failure. Resistance basically is the inability to induce ovulation. This could be mostly seen in your PCOS girls who are obese, who have insulin resistance, or they are hyperandrogic. CC failure is when the lady ovulates, but still there is no pregnancy. What to do in these conditions? Well, you can add the adjuvants. Literature supports the use of various adjuvants like your steroids can be started from the fifth day till the day of ovulation. In women who have got high LH, you can use pre-treatment oral contraceptive pills continuously for around 2 months, which reduces the ovarian androgen levels and also the LH. In girls who are thin, lean PCOS with good stromal thickness, that is, they have very high LH activity, laparoscopic ovarian diathermy has also been proposed. Coming to letrozole, recently it has been recommended by the WHO also as a drug of choice for ovulation induction, particularly in your PCOS girls. It's basically a third generation non steroidal aromatase inhibitor. It has got a high intrinsic potency and causes total suppression of your estrogen in a dose of 1 to 5 milligrams per day. I generally start with 2.5 milligrams OD from day 2 of the periods for the next 5 days. Now, the beauty of letrozole is that after 7 days, the estrogen level steadily starts to rise, which triggers the normal LH surge. Now, this rise is not supraphysiological, which is seen when you're using clomiphene citrate. Now, ladies who do not and have ovulation or who do not have any follicle growing, with the help of simple letrozole protocol, you can increase the doses to 5 milligrams. Some studies have also quoted a single dose of 20 milligrams also, or you could use the extended letrozole protocol. In these days we use letrozole 2.5 milligrams for continuous 10 days. Now what it does, it extends your FSH window, so all those women who are CC resistant will benefit with that. Studies have shown that it increases the number of patients who ovulated and thereby increased our pregnancy rates. There are also various papers who talk about the combination of letrozole with your gonadotropins, but they say even if you are using letrozole, it was more cost effective. Now, the beauty of letrozole is when you add it with metformin, it increases your pregnancy rate, your live birth rates, your ovulation rate, and also it reduces the abortion rates. So, particularly in girls who have PCOS, it's a good idea to combine metformin with letrozole. It increases your pregnancy rate. When do we use your gonadotropins? Well, letrozole combined with gonadotropins can be used in clomiphene failure when there is ovulation but still the lady is not getting pregnant. Why do we add letrozole? It decreases the total gonadotropin dosage and duration. Another important benefit or another important problem which we see when you are doing ovulation induction are your luteinized and ruptured follicles. You see on sonography the follicle looks wise, mature, 20 millimeters, but then when you're giving the trigger, it does not ovulate. It becomes luteinized like that only. Now, this can be seen in cases of women having mild infections, mild endometriosis. Now, in such cases, there have been studies which said that letrozole along with gonadotropins gave a much better result. The follicles ovulated and the pregnancy rate also went up. Coming to what would be the indications, when would I shift from letrozole to gonadotropins or from oral ovulation to gonadotropins? Basically, in our center, we do gonadotropin based IUI cycles only. I do not do oral ovulations with IUI. Now, what is the beauty of gonadotropins? It seems to improve the oocyte quality also. So, in all these women who have failed to respond to your oral ovulations, be it clomiphene citrate or letrozole, in spite of giving 3 cycles when you see no follicular growth, or after 6 ovulatory cycles, they have still not conceived. In these women, I would like to add gonadotropins. Also, in women who have previous history of miscarriages, when the age is more, when you had settled male factor infertility, or maybe a long standing case of unexplained infertility, it's a good idea to give them gonadotropin stimulated and then do the IUI. Now, what the studies say, what the literature say, well, it is which is helping us and saying that okay, in comparison with your more expensive and invasive techniques like your IVF or ICSI, COH with gonadotropins plus IUI appears to give us similar pregnancy rate. Hence, the importance of understanding and knowing a gonadotropin IUI cycle. Now, there are so many drugs in the market. Every pharma company keeps on bombarding you with different agents, be it an HMG, highly purified recombinant FSH, or plain FSH. Now, what does Cochrane say? The Cochrane review in 2015 said there was absolutely no difference in the live birth rates or the hyperstimulation rates when you're using either of these gonadotropins. Now, the basic issue is sometimes you see a more consistent response when you're using your FSH or your highly purified HMGs. With HMG, the dosage becomes a little bit tricky because you cannot reduce it beyond 75. So that is the only benefit of using an FSH or a highly recombinant ones. Let's try and understand what is the concept of this ovulation induction for us to know what particular dose would be helpful for a particular patient. This is the most common question which all of us ask. Okay, doctor, so from what dose we need to start? So let's try and understand what is the concept of this threshold. Now, all ladies have got a threshold of stimulation. If you're giving your gonadotropins or your overall ovulation induction till that threshold, you will get the response. If you have not yet achieved the threshold, there'll be no response and no recruitment. And if you bypass that threshold, you'll get a hyper response or the lady will be pushed into hyperstimulation. How do you come to know by this threshold? Well, there can be various factors like the history, previous history of hyperstimulation, her AMH, her antral follicular count, her age. These are the various parameters by which you would be basing your dosage of gonadotropins. Another very important aspect is the follicular monitoring. Now we see that some of us send our patients to the radiologist for doing the follicular monitoring. I would highly recommend that if possible, do your folliculometry on your own. If you have your radiologist friend doing the folliculometry, please tell them to use only transvaginal sonography. Why? Because follicles which are less than 10 millimeters in size are not hooked up on your abdominal ultrasound, and it is this cohort between 6 to 8 millimeters which is most likely missed and can lead to OHSs later on. So very very important aspect, that tell your radiologist to please inform us about this cohort. Coming to the regimens, you can have either your oral ovulations combined with gonadotropins or maybe followed up by the gonadotropins. When the gonadotropins follow up their oral ovulations, they are started from the very next day as seen in this slide. Now, in this case, they'll just help in the growth of the follicle. Now, when you're using the gonadotropins along with your clomiphene or letrozole, they will add to the action of your oral induction and therefore will lead to more follicular recruitment in this group of patients. So, let's say you have a PCOS girl, I would add gonadotropin later on, and in a low responder or a poor ovarian reserve, I'll add the gonadotropins to begin with in the cycle. What is the benefit? Like I said, It reduces the cost of treatment because your gonadotropin requirement goes down. It also increases the follicular sensitivity to FSH, and it increases the number of your pre-ovulatory follicles. The endometrial lining is beautifully grown when you're using letrozole instead of clomiphene citrate without any negative effect on your pregnancy rates. Coming to the practical guide, how do we go about it? We have lots of papers talking about different dosages and all. So practically, how will you go about it? Let's say the patient came to you on the second, third, or fourth day of your period. First thing is, I do a sonography, I do a transvaginal sonography, check if my ovaries are both suppressed. There are no ovarian cysts, nothing. If you see that there is probably a retention cyst and you do not know whether it's a functional cyst or a non-functional cyst, probably you can do a serum estradiol levels. If the levels are less than 50 or 60 picograms, you can start the stimulation. Now, again, the dosage and the type of protocol would depend upon the lady's age, her AMH, antral follicular count, her previous history of any hyperstimulation, the type of ovary, either it's a PCOS patient, non-PCOS patient, there is stromal thickness, there is no stromal thickness. So these are the factors on which our stimulation protocol would depend. Now, coming to different case scenarios, let's say I started with a dose of 75 international units of HMG, or maybe recombinant FSH of 50 international units, starting from second day of her periods for the next 6 days, that is total 5 days. I'll call the patient back again on the sixth day of stimulation, do a TVS sonography and see, oh wow, let's say I got 1 to 2 follicles which are dominant, that is 8 to 10 millimeters in size, which means that I have achieved the threshold of induction in this particular patient by using this particular dose. So I'll continue the same dose for another 4 to 5 days, assuming that the follicles grow at a rate of 1 to 2 millimeters per day. Once the follicle have reached a mature size, that is, they're 18 to 20 millimeters in size, I do a Doppler ultrasonography to see how is the vascularity. And now I know that, okay, my follicles are mature, I have achieved the optimal threshold, and then the trigger would be given. Coming to another scenario. Let's say I find no recruitment after giving your HMG and FSH for the first 5 days. What do I do? Well, in first case, I like to continue the same dose. I'm not increasing the dose. I'm continuing the very same dose for 4 more days, and then rechecking the follicular growth after 4 days. That is total 9 days of stimulation. Wow, I finally got some follicles, so I continue the same dose, and then the follicle grows to its maturity. So this particular dosage and duration is the threshold for this particular patient. So basically, it achieved the same dose, achieved the threshold, but it took a longer time. There was a delayed response, which means that I opened up the FSH window. Now, in case there is the other option is that I increase the dose by half, that is to 75, I add another 75, so it becomes 150, and recombinant FSH by 75, give it for another 5 days. Now after 5 days, let's say, oh very good, the follicles have started growing, so we continue the same dose, and now the optimal threshold is raised. Other option is you gave and still there is no recruitment in spite of giving, increasing the dose of your gonadotropins, given for a prolonged duration of treatment. The third option is there are more than 4 follicles, which are 8 to 10, so you're pushing the lady towards OHSs, and this should ring an alarm. Or, all right, we are getting more than 4 follicles on each side, 4 dominant follicles around 10 so either I need to step down the dose or I need to cancel the cycle, because for an IUI, if I'm having more than 4 dominant follicles on each side, this is definitely a case of hyperstimulation. In the other group where I had no recruitment, maybe I can continue the same dose for another 4 days. Wow, the follicle grew, and finally I have achieved the threshold. Now you are being a little bit more. I say, no, I don't want to increase the dose. I don't want to do anything. I cancel this particular cycle. The other option is I become a little bit more greedy. I am not too sure. I increase the dose by another half. So your HMG increases to 225, your recombinant increases to 125. Now, this is where the problem begins. You get more than 4 follicles, which are dominant follicle more than 10 and by this time, the lady has already been pushed into severe OHSs. So, the whole point of showing this thing is once you have started a dose, if the stimulation goes well, if on sixth day of the scanning you see that okay, the follicles have grown, you continue the same dose. Don't be too optimistic and try and increase the dose to very high levels, particularly in your IUI cycles, because that suddenly open up, the threshold may be reached for that particular lady, and suddenly you'll see a surge where see lots of follicles getting recruited, and then you do not know what to do, and the lady ends up in having severe OHSs. How do you monitor this? How do you know that when I need to stop, what do I need to do? So basically, you need to do a transvaginal sonography when the lady comes to you on the second or the third day of your period to check that the ovaries are nice and suppressed. Then we repeat the sonography after 5 days of stimulation to see how the recruitment happened, and preferably call her every 2 to 3 days to see how the follicles are growing, and accordingly customize and taper the dose. There is no one particular dose which will act for all the patients together. So it needs to be customized. You need to see the patient every 2 to 3 days, do the folliculometry, and only then customize the dosage. Other options are, along with your sonography, if you're not very confident, you're getting a radiologist to do the scan. Like I said, tell him to do a transvaginal sonography. The hormonal test can also help you, the estradiol levels. Now, when you see there are more than 4 follicles on each side, better do an E2 levels. Get to know what is the E2 level of this lady. Am I pushing her into AHSS? Serum progesterone I generally do before trigger if I feel that probably there is a premature LH surge. This is the only time when I do a serum progesterone for this group of patients. Coming back to the protocol, like I said, there are various protocols. One is a step down protocol, step up protocol, chronic low dose protocols. Now, step down protocols is generally used for your IVF cycle when you read multiple follicles. You start with a higher dose initially. In IUI cycles, you can start with a low dose, maybe around 150. And then once you see that the follicles are recruited, you reduce the dose. So what will happen? The large follicles will continue to grow, but the smaller ones will start becoming attractive. The other option is the step up protocol, that is basically for your IUI cycles when you need 2 to 3 follicles. So it's going to recruit only a limited number of follicles, which will be a softer stimulation protocols, and then you can steadily increase the dosage. If you're using your recombinant FSH, then maybe by 37.5. If you're using your HMGs, then maybe by 75. Now what happens with this is that it recruits, it's much better than your step down protocol. In step down, you have lots of follicles which get restricted at a time, and it's difficult to control. So this kind of protocol is better for beginners, where you start with a softer protocol and then slowly build up and go on adding the gonadotropins. So the risk of hyperstimulation is much lesser when you're using the step up protocol. Other ones are the chronic low dose protocol, which you generally do in the very strong PCOS girls who have got too much of stromal thickness, absolutely very high AFC and AMH more than 5, and an antral follicle count of more than 20. So you do start with a very minimal dose, maybe by 50 recombinant FSH or 75 HMG, and give it for a longer duration of time. So you're trying to open up the FSH window. So you give it for 10-12 days, you see there's no dominant follicle growing. After 14 days, after 10 to 14 days only, are you going to increase the dose, and that also by a very minute increase, that is only 30 to 50% of your initial dose, and then rescan. Now various studies have shown that this does not decrease your pregnancy dose. It reduces in fact the risk of multiple pregnancy and also that of hyperstimulation. So it's a very simple protocol, but you need to have lots of patience to monitor the patient. Triggers, again, there are various triggers. You have your urinary HCG, your agonist triggers, which can be used in your antagonist cycles of IUI, recombinant HCG and recombinant LH, although not available so readily in India. We generally use the recombinant HCG or your urinary HCG as the trigger. Once your dominant follicle is around 20 millimeters in size with good follicular blood flow, that is the peak systolic volume of that follicle. The overall blood flow of the follicle should be more than 75%, which means it's a good oxygenated mature follicle. And the PSV, the peak systolic velocity, is more than 10, which means that now your follicle is ready. At that time, you give the trigger. Sometimes we do monitor the LH surge. So ovulation generally happens 24 hours after your LH surge. So with your LH kit, it can be monitored, or simply you can do the IUI 34 to 46 hours after your ovulation. We generally do the IUI after 36 hours in our clinic, and we also confirm the ovulation. Now it's up to you whether you want to confirm ovulation before doing the IUI or you don't want to do it. Some cases have also said that probably double insemination, one done at 12 hours post trigger and one done after 36 hours, may increase your IUI success rate, although there are various studies refuting this claim. So, for all practical purposes, you can do the IUI after an interval of around 30 to 36 hours after your trigger. Once you have done the IUI, the support, luteal phase support, needs to be given particularly in your gonadotropin cycles, because the luteal phase may be deficient when you're adding a gonadotropin, unlike when you're using an oral ovulation. Now, there are certain cases when you would want to cancel the
Rana,
cycle. What are
Rana,
these
Rana,
conditions?
Rana.
It could be
How many
either
cycles?
because there is no recruitment, there is no growth of the follicle in spite of stepping up the dose, or when you see more than 3 to 4 follicles. I said when we see more than 3 to 4 follicles, we do see it in E2 levels. Now, if your E2 is more than 1800 picograms per ml, it
Rana,
means that there
can
could
you
be a
conclude?
very high
Rana?
risk of multiple pregnancy.
Uh,
The other is when there are more than 4 follicles on each side
Dr.
with an
Rana,
E2.
can you conclude? Can you conclude, please?
Yeah, I'll conclude it. So
Oh,
basically, coming back to what are the precautions, maintenance of the cold chain is very important. Preferably use subcutaneous form of injections. Reconstituted injections must be used immediately, and be careful with your increasing the dosage. We need to start with the softer stimulation, and no matter how careful you are, your ovarian hyperstimulation is likely to occur, and you need your IVF friend to help you out if required. Remember that the response varies from patient to patient and in the same patient from cycle to cycle. Thank you very much. Thank you, Dr. Anamal.
Rana, how you know Bengali? Eh? Dhanyavad. Excellent, Rana. You are rock.
Thank you, sir.
Rock.
Thank you, sir.
So nice presentation and so effective presentation actually you made. No, it's excellent, excellent presentation. Really overwhelming. So, Rana, can I ask you one question? You said already that's a single versus double IUI. The success rate is actually same, I think, huh? But cost is more, stress
Cost
is more.
increases, and say, yeah, the pregnancy rate per se does not improve much. So we are not practicing that unless you know that the husband is going to travel somewhere and like you're really, really desperate. But I really do not think that improves its pregnancy success rate per se.
Okay, but in case of IUI, no, the semen preparation is also very important, and which
Absolutely.
actually this is you what method you preferred actually in case of IUI.
We generally use the swim up method if the husband's count and motility is normal or almost normal. If the husband has oligoastenospermia, then the sperm density method is sometimes used in those cases.
Okay, okay, fine. So thank you, Rana. Thank you. Thanks
Thank
a
you so
lot.
much.
We'll wait for your next lecture. Okay, now we can leave.
Thank you
Huh?
so much, Dr. Anamal. Thank you for the opportunity.
Thank you.
Thank you.
Hi, Kanika. Can you hear me? Kanika,
Yes, yes. Good morning, Dr. Anam. Can you hear me?
please on video, no? Okay, fine.
Yes.
Hi, Kanika. You're okay, no?
Yes. I just have a 2-month-old baby.
I know your baby is
Sleepless
small,
nights.
but okay, fine. Can you share your screen? Kanika, just share your screen, no? Just keep your video on.
One second.
Just share your screen, okay?
Yes. Yes. Just 1 second.
Okay, just on.
Is it visible?
Yeah, it has come. Right. Just open it in a slideshow.
Okay.
Hello, Kanika. Open it in slideshow. No?
Yes, yes, yes. Yes. Slides?
No, no, that's not right. What you have to do, you have to go to slideshow. Go above.
Dr. Anam, one second.
Huh.
Just give me one second. I think there's some problem.
No, no, I'm
Let us
telling
log in
you
and log out.
how you solve this problem. I'm telling you. Just go to the slideshow above. No, there is a option of file, home, insert, design. Go to slideshow. Can you hear me?
Yes. One second.
Click
Yes,
slideshow.
now I can hear you, Dr. Anam. I'm sharing my,
Okay.
just a second. I'm sharing my screen.
Huh.
Uh, just see if you can see my PowerPoint.
I'm seeing now. Just make it in a PowerPoint show.
Yes. Can you see it?
No, no. You have to. What you have to do? Just go to the slideshow. The above. You see the insert,
Okay,
design,
okay,
animation.
okay, okay.
Slideshow.
Yeah, yeah,
Go
yeah,
to
yeah,
slide.
yeah.
Click.
Okay, okay.
Okay. Now
Now,
there is
okay,
option
okay.
setup slideshow. There is option setup slideshow. Okay. Click there. Setup slideshow. Click
Okay.
setup slide. Where? Now browse by an individual. Click it. Browse by an individual. Click it. Array. Do again. Hello, Kanika. Hello, Kanika. Can you hear me? Hello, Kanika.
I can hear you. Yes, sir. Actually, some
Array.
problem with the laptop. Just one.
No, no, no,
I
no.
can
Just
hear
click.
you.
I'm showing you. Just click the slide. Setup slideshow. Setup slideshow.
Yeah,
Click karo.
I'm
Okay.
clicking.
But
It's
it's not
not.
changing. No.
It's not changing. That is the problem.
Uh,
One second.
Again,
I'll share it again.
again.
I'll share.
I share it. Your net is very slow.
Just a Dr. Anam, can you continue the next? I'll just join in the next one. One second.
Actually, Dr. Sandesh is busy in emergency. That's why I call you earlier.
One second. One second.
Try it. No problem. Try. No problem.
Just give me one second. Dr. Anam, can you hear me?
Kanika. Hello, Kanika.
Yes, Dr. Anam. Can you hear me?
Just open your PowerPoint. Just open your PowerPoint. I am telling you how to connect. Yeah? Just open your
Actually,
PowerPoint.
yeah. Actually, my computer is hung. I'm using another. I'm logging in through another device.
Oh, okay, okay, okay. Open karo.
Just give me 2 minutes. I'm logging in through another device.
Okay.
Okay.
Okay. Is currently working as a consultant in Mumbai in Indira IVF Limited. So she is a excellent infertility specialist in this field. I will invite Dr. Kanika Kollani. Hi, Kanika, how are you?
Hello, sir. I'm fine, sir. Thank you for inviting and thank
Thank
you
you.
for giving me this.
Hi, Kanika, how are you?
Hello, sir. I'm fine, sir. Thank you for inviting and thank
Thank
you
you.
for giving me this.
Hi, Kanika, how are you?
Hello, sir. I'm fine, sir. Thank you. Treatment options, whether to give natural planning, whether to give IUI option, whether to go for ICSI, when to do pre-implantation genetic screening. So whether this patient needs laparoscopy or not. So we are always confused and we don't know what is the right way to go. If we understand things very well, infertility treatment is very, very simple. It's a stepwise thing. There are certain basic ABCs of every condition, which I'll be covering in today's topic. So, today, what topics I'll be covering are evaluating female infertility, evaluating male infertility, when to do natural planning or IUI or IVF. This is the biggest question in our minds. and the case scenarios. There are certain case scenarios which we'll discuss, and also their management. Okay, so first of all, I would like to define infertility. So, infertility is defined as failure to achieve pregnancy within 12 months of unprotected intercourse or therapeutic donor insemination in women younger than 35 years, or within 6 months in women older than 35 years. So, this is a recent addition in ASRM definition of infertility. If the woman is more than 35, we are not supposed to wait for 1 year. We are supposed to call them infertile, start their testing, and give them treatment options within 6 months itself. After 6 months.
So
Now,
new definition a little bit change actually. The age
yes,
is also
yes.
very important in this
Mhm.
definition.
Yes, sir. Right, sir. Age is very important. And as we all know, recently there is an increase in demand of infertility services. Also, because today there's a tendency of women to delay childbearing because of their work, so that desired reproduction is condensed into a shorter interval than before and at a more advanced age. So, we have so many females who are actually wanting to focus on their careers, they want to become independent, and then they think about marriage and pregnancy. So, by the time they think about pregnancy, we see that their AMH is quite low. So, now the tendency has increased of women to delay their conception. Also, there is an increase in effective treatments, and even people are aware. They are seeing patients who are treated in their neighborhood, in their offices, who are actually trying to conceive, and they took treatment and they became successful. And now we have so much of advancement in technology, and even the formation of blastocysts, everything has increased, success rates have increased. Today we land up with so many beautiful blastocysts in majority of patients. So this is also because of the new technology that we use. Also, there is an increased awareness of such treatments. Nowadays we come across patients who are actually reading everything on Google. They know everything. They know that they are not supposed to wait for their 10th wedding anniversary to come to an IVF clinic. They know that if it's been 2-3 years, there is something wrong with them, and they come to us for treatments. In fact, in Mumbai, I would like to tell you something funny. I have patients who actually come with videos, doctor, do agonist protocol for me, or doctor, do antagonist protocol. That is, I think, is better for me. So I have patients like that also. Now let's come to the causes of infertility. So conventionally, and since times immemorial, infertility causes have been divided into three parts: male causes, female causes, and male plus.
Am I audible, Dr. Anam? Hello? Hello?
Hello. Can you
Am I
hear
audible?
me?
Yeah, yeah, yeah.
Your light not okay. You are not looking good.
Just a second. I think something wrong with the camera.
All
One
right.
second.
Just light in front of your light is the problem actually. Light. Just see behind a white background. No.
I think there's something wrong with the camera again. Actually, this device is not mine.
It's right. It's right. Okay.
Okay.
Just share the screen.
Yeah. Uh, One second. I'll just share. PPT. Okay, Dr. Anam, now I am on, I will share.
Hmm.
I am sharing the screen. Okay, entire screen. So I can't see the PPT actually. I'm so
Arey,
sorry for this.
first open your presentation.
Yeah,
Listen to me. First open your PowerPoint. First open
I'm
it.
opening. Yes, I've opened the
Okay.
PowerPoint.
Go to the share option. Okay. Share below. You see this cam, mic, share, invite. Share karo.
Okay,
Hmm.
one second. I've opened this PowerPoint.
Ah,
slideshow.
just keep just no no just keep PowerPoint on. Okay.
Okay. Yeah.
Now go to the share option.
Okay. Okay.
Okay.
Yeah.
Now you see share screen. Click share screen.
Yeah.
Yeah. Now again blue button on karo share
Yeah. Yeah.
screen.
I got it. I got it.
Okay. Then go to window. Go to window. Huh? Go to
Yeah.
window.
Can you? Yeah. Can you
Okay.
see it now?
Now you are seeing right, right. I am seeing you. Right, right. It's
Yeah.
okay. Now what you have to do,
Setup
go
slideshow.
to slideshow. Press slideshow. हाँ then setup slideshow में जाओ. Setup slideshow में जाओ.
Yeah.
हाँ now setup slideshow click करो यहाँ पे. हाँ यहाँ पे. Then
Yeah.
click. Now second वाला the open by an individual no press करो.
Browse by an individual. Yes.
करो. Okay, 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 okay.
Yeah.
Done. Now
Can you?
click slideshow. A cup.
Yeah.
Here. Now see the
Now can you
perfect.
see? Yes.
Now.
Okay. So I'm so sorry. Actually, I'm with a new
Sorry,
device.
I know you are so busy. That's why I teach only Renoy. But okay, no problem.
Okay.
Listen, I will introduce you.
Yes.
This is Dr. Kanika Kallani. She's a very young, talented gynecologist and the IVF specialist. She's currently working in Indira IVF, Borivali, Mumbai. Uh, she's now actually new mother. So congratulations to Kallani.
Thank you so much.
Kallani, you can now present your presentation. Okay.
Yeah. Thank you so much, Dr. Anam, and I'm extremely sorry for the inconvenience. Extremely sorry, everybody. And
Okay.
namaste. I'm Dr. Kanika Kalyani. I am the chief gynecologist and fertility specialist at Indira IVF Borivali, Mumbai. So today the topic of discussion that I am going to take over is standardizing evaluation and treatment in infertility. So this is one of the very basic topics. We all are confused. So when we come out of our post graduation, there is a plethora of tests. There are a plethora of treating options in front of us. When an infertile couple comes in front of us, we are absolutely confused whether to go for natural planning, whether to go for IUI, whether to go for IVF. And there are so many blood tests or there are so many radiological tests, and we are always confused what to do. So today we are going to streamline and see what the guidelines say about managing at a very basic level. Now, so what all are we going to cover today? The first thing is evaluating female infertility, then evaluating male infertility. Then we'll discuss when to go for natural planning, IUI, IVF, and then we'll discuss certain case scenarios and their management. Now, let's see how do we evaluate a female who is infertile. First of all, let's cover up the definition. So there is a recent change in the definition of infertility. Infertility is defined as failure to achieve pregnancy within 12 months of unprotected intercourse or therapeutic donor insemination in women younger than 35 years. Or now this is a new addition within 6 months of women older than 35 years. So this is latest added by ASRM. So if a woman is more than 35, we have to evaluate even if she is not conceived in 6 months of unprotected intercourse. The causes of infertility conventionally have been divided into one third male causes, one third female causes, and one third both male and female. But recently, ASRM has given a major contribution to unexplained infertility. Now, very important, what are those three things which we feel can attribute to unexplained infertility and they cannot be diagnosed perfectly? So, first thing is there can be a ciliary defect in the tubes. Secondly, there can be a fertilization defect. And thirdly, there can be a hatching defect. So, all these three factors may contribute to unexplained infertility. Now, when should a couple go for infertility evaluation? When should we investigate? So, first of all, obviously, by definition, whoever is there and or people at high risk of infertility, women older than 40 years, oligomenorrhea or amenorrhea. If you're already suspecting known or suspected uterine tubal or peritoneal disease, stage 3 and stage 4 endometriosis, directly we should investigate as early as possible. Known or suspected male subfertility. Now, evaluation of infertile female. So, what all is included? The first thing is we have to ask about history. We have to take menstrual history, any history. So we have endometriosis. Many young girls come to us who have been operated in their teenage. They had severe dysmenorrhea and they had endometriotic cysts. Some of our females have dermoid cysts in young age. History is very important. Physical examination again is very very important. Any webbed neck, any thyroid swellings, any a female has absent breasts, all that is also very important. Then for diminished ovarian reserve testing is something that has recently come into picture. So ovarian reserve testing includes AMH, antral anti-Mullerian hormone, and antral follicle count on transvaginal ultrasound. Next comes the tubal factor. The tubes, we need to check whether the tubes are patent or not. We can check that by hysterosalpingography or HSG, or we can also do the chromoperturbation test by laparoscopy. Another factor we have to investigate is the uterine factor. In the uterine factor, the best tool for diagnosing any abnormality for us is transvaginal ultrasound. Sonohystrography, hysteroscopy, again nowadays we are using a lot of hysteroscopy. So we need to see if there is any fibroid, any adenomyosis, if there is any fluid in the endometrial cavity. Nowadays even we are seeing isthmoseals in women with previous cesarean sections, and that is also leading to infertility. Now, there are some other investigations which need not be done routinely, but they need to be done only in certain cases. So, first of all, rubella testing, PAP test or LBC. PAP test in India, we do it as an opportunistic test. So, whenever an infertile couple comes to us, we do the PAP test for the female, preferably nowadays liquid based cytology. Vitamin D, especially vitamin D deficiency in PCOS, is leading to infertility. There are many studies supporting this. Serum prolactin, a laparohysteroscopy not indicated in all cases, but where we feel we should do, it is done. Endometrial biopsy. Now, this is very, very important. So, when the woman has endometrial thickness more than 12 mm, I have seen an infertile woman coming to me who her endometrial thickness was 16 mm. In these cases, unless we get a normal biopsy report, we don't proceed with the treatment. And I have seen malignancies in such women. So endometrial biopsy in endometrial hyperplasia women is very very important. Breast imaging in certain cases. Now evaluating male for infertility. Reproductive history, physical examination is very very important. Examination of the external genitalia, measurement of the testes, presence and consistency of vas deferens epididymis. Now this is something which is ignored. So it is always very important to physically examine the male. Many times the male is only asked to give semen and physical examination is not done. Presence or absence of varicocele, secondary sexual characters, digital rectal examination. Semen analysis, we all know, is the cornerstone of male infertility evaluation. Further diagnostic workup, that is endocrine evaluation, serum FSH, total testosterone, LH, prolactin, is indicated in men who have abnormal semen parameters, particularly when the sperm count is less than 10 million, or there is impaired sexual function, or there are other clinical findings that suggest a specific endocrinopathy. Also, if the sperm is not there, not found in the semen, we need to do post ejaculatory urine analysis. The male may be having retrograde ejaculation or scrotal ultrasound and truss in certain cases. Now, let's see what the guidelines say. The ASRM 2015, same, they say that evaluation need to be done after 12 months. Earlier evaluation warranted after 6 months if the woman is above 35 years, and it may be justified where we have certain doubts, like we discussed: oligomenorrhea, amenorrhea, uterine tubal peritoneal disease, or endometriosis stage 3 4. The diagnosis includes ovulatory function, patency of the tube, and reserve testing. Now, guidelines say that ovarian reserve testing is not to be performed routinely but may be used in women undergoing stimulation. Now, in this, also one very important point I would like to stress on is the correlation between AMH and antral follicle count. It should always correlate, and the more is what we rely on is what we see. So if AMH is very high, but we see only 3 or 4 follicles, then we have to doubt the lab standards of the lab which has done the AMH. So what we see is always more important. Now, routine laparoscopy is not to be performed. It is not recommended. Postcoital testing, endometrial biopsy, definitely not to be performed as a routine test. Male evaluation, Indications are same. Men having concerns about their future fertility also merit evaluation. Now, earlier evaluation may be warranted if there are specific male or female infertility risk factors. Thorough history and evaluation is extremely necessary, and semen analysis is very, very important. So, if semen parameters come abnormal, the next step we discussed endocrine evaluation, trust, urine analysis, and specialized tests only in certain cases. Now, that was about evaluation, when to go for natural planning, when to go for IUI, and when to stop doing IUI and go for IVF. Now, who are the ideal candidates for natural planning? The couples diagnosed with unexplained infertility, mild to minimal to mild endometriosis, mild male factor infertility, and this in couples who have been diagnosed at 1 year of unprotected intercourse. Also, very important in natural planning nowadays, what we use is urinary LH kits. So we tell women to start checking their LH levels in the evening hours every day from the, if the cycle is of 28 days, we tell them to start checking from day 9 or day 10. And what we believe is that the day the LH comes positive in urine test, 72 hours from that point the woman is the most fertile in her cycle. So we tell them to have timed intercourse during those 72 hours, and it has really shown many results at our clinic. Now, what do the guidelines say? So, Fertile Stellar 2016 says time to conception increases with age. We all know this, that as age increases, it's very difficult to conceive. So, devices designed to predict ovulation may be useful for couples who have infrequent intercourse. So, this is what I was talking about, LH kits. They have been very, very useful of late for couples, especially in Mumbai, who are very busy in their hectic schedules. Frequent versus less frequent intercourse definitely has more success according to ASRM. Now, what are the indications of IUI? So, ideally, when the couple has tried for natural cycle 3 to 4 times or for 6 months, then it's time that we talk to them about IUI. So, what are the indications of IUI? So, male factor infertility, subnormal semen parameters, erectile dysfunction, hypospadias, impotence, couples with HIV discordance. Female factor when the female has anovulation, minimal to mild endometriosis, cervical hostility, leap, cone biopsy, cryotherapy, or when it is done, then IUI is indicated. When the couple has to go for IUI with donor sperm, in if the male has azoospermia, hereditary disease, severe RH incompatibility, unexplained infertility. Now, when should IUI not be done? This is also something very important. We see at our clinic that patients come with 8 IUIs, 9 IUIs, and they are never stopping. So, and there are certain indications where IUI has absolutely no role. So, first is bilateral tubal block, severe OATS. So I have seen patients who are having sperm count 2 million and going on with IUI. So that is not indicated. Age more than 40 years, again, ASRM recommends that after 38 years, IVF has better success rate than IUI. Active PID and IUI 3 to 4 cycles already done. So that is the last that we do. If that does not help, then that means there can be some fertilization defect, there can be some hatching defect, or there can be some tubal ciliary defect. Now, what are the indications of IVF, and when is the right time for a couple to go for IVF? So, a woman with bilateral tubal block, doubtful patency, endometriosis stage 3 and 4. In fact, let me tell you with my experience, endometriosis stage 4 and all, even there are many studies also, and we have seen it that the egg quality and embryo quality gets really compromised if in advanced stage endometriosis. Moderate alterations of semen characteristics, unexplained infertility, previous failed cycles of ovulation induction or IUI, and uh, women with other severe complications. Natural planning can be tried for 6 months in indicated cases. So this is the take home message. 6 months, try natural planning. If 6 months natural planning does not succeed, you can think of IUI, or if the couple needs donor sperm, we have to directly jump to IUI. And then when to think of IVF ICSI, if 3 to 4 cycles of IUI fail, bilateral tubal block, severe male factor, and unexplained infertility, according to NICE guidelines, if 2 years of unexplained infertility are there in a couple, then you have to directly go for IVF rather than going for IUI. Now let us come to certain case scenarios and their management. Now, there is this one case. A couple comes to the clinic. Wife is 26 years old, husband 27 years old, married since 3 years. Wife's both fallopian tubes are patent. Her AMH is 3, endometrium 9 on day 18. Semen parameters are normal. So, overall, everything is normal. It's a young couple with 3 years of infertility. So, how should we go about in the management of this patient? Now, when all reports are normal, then what we label it as unexplained infertility. So, ideally, in unexplained infertility, what we suggest is the right way to treat is letrozole combined with IUI. So, we can give letrozole for 2 to 3 cycles, and if in that also the couple doesn't succeed, then 3 to 4 cycles of IUI, then we have to think about IVF. So let's see what the guidelines say about unexplained infertility. So ASRM says that in unexplained infertility, IUI with ovulation induction, that is ovarian stimulation, is much better than unstimulated IUI. So we are always confused whether we should go for natural cycle IUI or stimulated. So ovarian stimulation is always better. Letrozole plus or gonadotropin plus timed intercourse is not recommended. We always have to think about IUI in unexplained. Clomiphene citrate or gonadotropin plus IUI is better than natural cycle. So overall, bottom line is natural cycle is not recommended. You should always go for ovulation induction, and the best option is in ovulation induction is letrozole plus IUI. Less than 38 years old, IVF is not the first line therapy in such women. Now, this woman was 27 years old. More than 38 years old, immediate IVF in women is associated with higher pregnancy rates. So, this is what ASRM says. And NICE guidelines say that even after 2 years of unexplained infertility, including that 1 year of trying before tests, they are directly offered IVF and they should not be offered CC. So next case is a 30 years old female who came to infertility clinic with inability to conceive since 2 years. Her cycles are irregular and USG shows bilateral enlarged ovaries with increased number of follicles with peripheral distribution. Semen parameters are normal and bilateral tubes are patent. So what should be our plan of action to help this lady conceive? So a very important suggestive line here is enlarged ovaries with increased follicles. This is a case of PCOS. So, how do we manage and what do the guidelines say? So, in PCOS, the first and foremost important thing is diet and exercise. So, lifestyle modification is something that we all have to recommend all women with PCOS. Now, we in PCOS, the recommended treatment will be going for ovulation induction with IUI. Ovulation induction generally we prefer now again letrozole. And if letrozole is not available, we offer them CC, explaining them the risk of multiple pregnancy. Now let's see what the guidelines say. So in PCOS women, the first line for ovulation induction is letrozole. If that is not available, go for CC. Explain the multiple pregnancy risk. Always CC plus metformin is better than CC alone. So it's always better to add metformin with clomiphene citrate. Gonadotropins are the second line if first line in ovulation induction drugs fail. Again, even if we are going giving gonadotropins with metformin is better than gonadotropins alone. Then, if the woman is CC resistant, then we can go for gonadotropin or lap ovarian surgery. A 26 years old female, married since 4 years, keen to conceive, comes to you. HSG shows bilateral tubal block. Her AMH is good, 2.6. ET is 8 good. She has taken AKT treatment. So, this is a classical case of tubal factor, tubal block. So, how will you manage? So, she is a direct case of IVF. And again, let us see what is the role of tubal surgery in the era of assisted reproductive technology. So, this woman definitely has tubal factor, but on the ultrasound, we also have to see whether she has hydrosalpinges. If she has hydrosalpinges, it's always better to do a salpingectomy before going for IVF. Now, there was this randomized clinical trials which compared pregnancy rates and outcomes with IVF for women with hydrosalpinges with or without prior laparoscopic salpingectomy. So, they showed that salpingectomy restores their pregnancy rates and live birth rates to levels similar to those of women without hydrosalpinge. So, nowadays it's strongly recommended. And also in couples with multiple IVF failures, it's always better to go for salpingectomy. Now, how to manage tubal factor according to the guidelines. So, if there is a proximal tubal obstruction, young woman, we go for tubal cannulation. If there are mild hydrosalpinges, young woman, AMH normal, semen is normal, we can go for laparoscopic fimbrioplasty or neosalpingostomy. In surgically irreparable hydrosalpinges, it's always better to go for laparoscopic salpingectomy or proximal tubal occlusion and then go for IVF to improve the IVF success rates. Microsurgical anastomosis for tubal ligation reversal also has some good evidence, but when we are trying, so we often find couples who want to correct tubal, they want to go for tubal corrective surgery. So we have to consider some factors when we are deciding for IVF or a corrective surgery. One is age of woman and ovarian reserve. So if her AMH is very, very low, there is no point in waiting for natural conception after tubal corrective surgery. Number and quality of sperm. Again, we need a good sperm count for natural pregnancy. Number of children desired, site and extent of tubal disease. If the tube is badly damaged, it's very difficult to correct it again. Presence of other infertility factors,
Kanika,
and the experience of.
sorry to
Yes,
disturb you, Kanika. You have only 2 or 3 minutes. Okay,
yes,
you
yes.
can.
I'll just wrap up. Yes. Now, very important in endometriosis, very important. We should know that it's always not recommended to do laparoscopy in endometriosis. So, laparoscopy for minimal to mild cases is unwarranted. Stage 1 or 2, less than 35, you should go for expectant treatment or IUI or and with ovulation induction. Stage 3 or 4, conservative, but there are only three indications for doing surgery. One is patient is having severe dysmenorrhea symptomatic woman, then we should go for surgery. Second, we are going for IVF and we feel that the endometrioma will come in the way of ovum pickup. And third, when we are suspecting malignancy. So that is the only this thing. And stage 3 and 4, it's always better to go for IVF. Again, adenomyosis. So we all know adenomyosis. We come across in our IVF practice. Adenomyosis and IVF treatment. There are studies which show reduced fertility outcomes related to the presence and extent of adenomyosis. So in such cases, GnRH analog treatment with add-back estrogen therapy has shown positive effect on implantation rates. So what we do is we give them GnRH analog for 2 or 3 cycles, and then we do go for embryo transfer according to the extent of adenomyosis. So that is proven by evidence. FET after long-term GnRH treatment improved implantation rate and ongoing pregnancy rates. It may produce a window of time for implantation. So this is what I mean. Give them 2 or 3 months of this GnRH analog, create a window of implantation, and then go for embryo transfer. Surgery is only indicated in symptomatic women with repeated failures. Now, this is about male infertility. I'll just quickly share the guidelines of non-obstructive azoospermia. What do the ASRM people say? In non-obstructive azoospermia, it's very important to do genetic counseling. Detection of genetic abnormalities in men with NOA is very, very important. First line therapy is endocrine therapy associated with hypogonadotropic hypogonadism, and it allows natural conception in many cases. And hypogonadotropic hypogonadism associated with exogenous steroids or androgens is associated with a variable time to sperm recovery and may be assisted with, in these cases, we can give CC or HCG. Varicocelectomy should be considered in men with varicocele associated NOA prior to sperm retrieval. Reported sperm retrieval rates in men with NOA are highest using microtessay. Other options, including donor insemination and adoption, should be discussed with the patient. Now, obstructive azoospermia, what do the ASRM people say? So, we recently also in NOA, I would like to share that we recently did microtisa and tessay, and we actually found 6 to 7 sperms, and we could make BV grade embryo blastocysts. When obstructive azoospermia results from vasectomy and no coexisting female infertility factors, microsurgical reconstruction is generally preferred in obstructive azoospermia over sperm retrieval and IVF ICSI. But IVF ICSI is the best choice in the following cases. So again, like tubal reconstructing, when the woman has rapidly diminishing ovarian reserve due to age or other conditions, when there are coexisting female infertility factors that require IVF, concomitant secondary male infertility condition in the male partner, and likelihood for of success with sperm retrieval ICSI in such cases is greater than with surgical treatment. So that's all from my side. Thank you, Dr. Anam, for providing me with the opportunity. Thank you so much.
Thank you, Kanika. It's excellent presentation and you made very useful actually. So thanks God that ultimately you connected. Um,
Yeah.
I have only one question, Kanika. That
Yes.
in case of actually no, uh, the what is the actually in case of male fertility? What is the cutoff line actually? Whether he will go for IUI or IVF or ICSI. What is the cutoff
So
point actually?
basically, yeah. So, Dr. Anna, when we consider them for IUI at our clinic, usually we prefer of to them to have sperm count of at least 10 million, 10 to 15 million after semen wash. And when the sperm count is less than 5 million, we definitely do not offer them IUI at all, and we directly tell them for to go for ICSI,
Okay.
ICSI.
Thank you, Kanika. Thank you for your nice presentation. See you
Thank you,
tomorrow. Okay. You
thank
can
you,
leave.
thank you, thank you.
Okay, fine, fine.
Yes.
Hi, Sandesh. Sandesh, can you hear me?
Yeah, I can hear you. Yes.
Okay. Oh,
Should I start my lecture?
yeah. Just open your PowerPoint. No?
Okay. Before I start, I'll just there's a small change. I'm going to present the laparoscopic topic today and the hysteroscopic fertility enhancing tomorrow.
Okay, no
So
problem.
it's a very huge topic. So what I have done is I have selected from my practical aspect why I am involved in the infertility setups. I am not a IVF specialist. I am just an endoscopic surgeon.
Your
But I work.
fertility enhancing surgeon.
Yes, very much. And I work with many centers, so I know exactly the indications for which the IVF specialists seek an laparoscopic surgeon or a hysteroscopic surgeon. And
Okay, Sandesh, just open your PowerPoint, then I will introduce you. Then you can start. Okay.
okay. Now this is a video.
Just share it now. Okay, it has come.
Okay, it is there.
It is there, right? So this is Dr. Sandesh Kade. She is a very renowned, world famous laparoscopic surgeon. He's a very good friend of mine. He's a very good speaker. I would like to. He's currently actually working in. He has own center, Solapur Sunrise Hospital in Maharashtra, and he's also working in Dubai, Abu Dhabi. So he's actually international figure. Now I'd like to invite Dr. Sandesh Kade to present his case.
Okay.
Start.
Thank you very much, Inam, for this wonderful opportunity. It's a huge topic. So what I have done is I have selected one particular condition, which of late we are finding too many surgeries being happening for this, related with the infertility specialists and or the fertility centers and the laparoscopic centers. Now, we all know that WHO has given that the cesarean rate has to be between 15 to 20%. Okay. And the condition actually right now all over the world is that it has already surpassed this incidence, that is more than 20%. Some centers, some countries are actually experiencing almost 50% of cesarean sections for every delivery. And unfortunately, most of these patients who have gone with cesarean section experience secondary infertility. And the most important reason for that is the adhesions that develop. So you have one condition where the uterus itself adheres to the peritoneum and the abdominal wall, and the uterus immediately post cesarean section is very large, so it adheres at a very higher level. And as the uterus involutes and the uterus size goes down, you find that the fundus of the uterus is fixed up. So what happens is this cervix get pulled up and it goes retro behind the pubic symphysis. And these patients, after few years, when they experience the secondary infertility, they go ahead for the examination, and there they find that this cervix is not accessible very easily. These patients, if you post them for IUI, their IUI is difficult, and if they unfortunately go for IVF, the embryo transfer is also very, very difficult. And these are the reasons why these patients are referred to us for correction of this ventrofixed uterus. And it is very important that these patients, we perform this surgery in the minimally invasive fashion, that is with laparoscopy, and we avoid adhesions. So we avoid the laparotomy to just release the uterus. And most important, the laparoscopy is an excellent and a very feasible and very easy method to learn and perform these surgeries. So I've just selected one particular surgery for today's presentation, that is ventrofixed uterus, and how to go about it, releasing that uterus adhesions, because this is nowadays getting as a very common indication. And fortunately, after many cases, we have found out that there is a standard fixed method of performing this surgery, which is very safe, easy to learn, very easy to practice in everybody's hands. And so this is my presentation of managing the ventrofixed uterus leading to secondary infertility, to help us perform a better IUI or embryo transfers, or even these patients, if the tubes are healthy, can go ahead for natural pregnancies.
Hello friends, the incidence of cesarean section is on the rise. In spite of all good surgical principles and precautions, adhesions do happen. When the uterus adheres to the anterior abdominal wall, it is called as a ventrofixed uterus. This leads to chronic pelvic pain, secondary infertility, and during labor, it can lead to delayed delivery time, increased incidence of cesarean sections, increased operative time, increased bleeding, and most importantly, it is very potential for bladder injuries. We all have been performing these surgeries so frequently, so we feel it is time for us to standardize these surgical steps, because standardization helps us to make surgeries safe, effective, and time efficient. This is a case following one cesarean section. The adhesions were dense on left side and minimal on the right side. The cervix was pulled, could not be seen on post-speculum examination. This case we could not perform IUI, and so she was posted for the surgery. We have designed 6 steps. When you standardize, you will appreciate that with every case, your surgeries are improving. So we recommend to perform this particular surgery in following steps. Step 1, we expose the left round ligament. The incision starts from the cornual end of the uterus to the lateral pelvic wall. The direction of dissection always has to be horizontal with blunt instruments. Be careful at the lateral end of the round ligament, where it is in close contact with the external iliac artery and vein. So there one has to be very gentle. Step 1, delineating the left round ligament. Grasp the round ligament near the cornual end. The anterior abdominal wall gets pulled. Appreciate the direction of round ligament, and also appreciate the fat which belongs to the preperitoneal layer. Make small incisions between the round ligament and the preperitoneal fat. Extend the incision liberally so that the layers separate. Once you have made the incision, then you can make more incisions on the medial side where it is densely adherent. This allows us to separate the two layers. The fat has to be pushed towards the abdomen, and the incisions have to be very gentle on the posterior aspect. On the lateral most aspect of round ligament, there would be great vessels like the external iliac artery and vein and corona mortis. So be very gentle at this dissection. So this separates the whole round ligament. And so this is the end of step 1. Always perform this as the beginning step. Step 2 is to identify the left uterine arteries. The direction of dissection is vertically opposite. Be gentle on the posterior wall dissection because this is a thin layer of broad ligament, and avoid buttonhole. With every step of dissection, keep moving downwards below the paravesical area. The uterine artery traverses from the lateral pelvic wall, reaches the isthmus of the uterus, and then it ascends upwards. The dissection in this area is vertically opposite. Like here you can appreciate I am pushing the two instruments apart in vertical direction. But the trick is mostly the dissection is towards the abdominal wall. There are such small tributary vessels which need to be respected, or else they bleed and spoil the field. Of course, it is not a very torrential bleeding unless you are gentle on the uterine artery itself. So we are dissecting in the paravesical area, which is actually a avascular area. And here you can appreciate the uterine artery, which is actually crossing from the lateral wall and reaching the uterus. So the dissection goes below the level of the uterine artery. So appreciate the uterine vessel, which is bluish in color and tortuous in nature, and the dissection happening above the uterine artery level, and we are delineating the uterine right from the lateral pelvic wall to its course on ascending on by the side of the uterus. So this is step number 2 to delineate the uterine artery. This step is almost always very easy without blood loss, and it is very simple but needs meticulous rules to be followed. That is vertical dissection by appreciating the paravesical and the posterior leaf of the broad ligament. Step 3 is the repetition of step number 1 on right side to delineate the right round ligament from cornual end right up to the lateral pelvic wall. The only precaution is take care at the lateralmost end near external iliac vessels. Steady the right round ligament and give good traction. Anticipate the direction in which the round ligament is traversing. Lift the peritoneal fold. Appreciate the preperitoneal fat as well as the direction of round ligament. Cut exactly below the preperitoneal fat. This releasing incision will give way to CO2 gas, and you can appreciate here the round ligament. Do not cut the round ligament but remain above on the peritoneal surface. This separates the fat, and now it is very easy for us to identify the fat and push it towards the anterior abdominal wall. So this separates the right round ligament. Be careful of the vessels here. Step 4 is to identify the right uterine arteries. The dissection goes in the right paravesical medial to the obliterated umbilical artery. So keep dissecting, moving the instruments vertically, identify the uterine artery crossing, and remain above the uterine artery and go caudal direction in the paravesical area. Step 5 is the most crucial step to prevent bladder injuries, and that is to create or identify this potential space that exists between the uterine adhesion and the bladder. This is the area where the bladder keeps on distending and emptying itself. In this step, we start from the left uterine artery. We identify the fat which belongs to the bladder and we are dissecting under the bladder. We are trying to push the bladder above and we are creating a space and identifying the cervix and bladder. So appreciate with every step we are lifting the bladder up and gently trying to push it. So as we progress with blunt dissections, this is the area where the bladder used to distend and empty. So this place is always devoid of any adhesions. And our aim is to go from one uterine artery to the other uterine, that is from left uterine artery to the right side. One has to develop an eye to identify the texture of the bladder and that of the cervix and vagina. If there are no adhesions below, one can directly go ahead with dissecting the lifting the bladder as well as pushing it down. So here we have created this window and this window would be taking us from left side of the adhesion to the right side. And so once we have done this dissection, the bladder is pushed down. Here you can appreciate the texture of bladder as well as the movements of the Foley's bulb.
Dr. Sandesh, can
If
you
you
please
are aware how the bladder looks, then you can identify it and release it of its adhesion and it would
Sandesh,
be pushed
Yes.
down or it
can you
automatically
please
snaps
fast
down.
forward?
So here I am just cutting the translucent.
Yes, sorry.
Can you please fast forward because no, there is time constant. No, we have only 5 minutes more.
Yeah. Okay, no, the video will end in now 2 minutes. Okay, I'll go ahead.
Okay, okay, okay.
Yeah, it's a pre-edited, so it will end up. No problem.
Okay.
Area that is flimsy adhesion and I am pushing the bladder. The bladder is getting retracted down. So this creates the potential window which almost always exists in a case of ventrofixed uterus. Remember, the uterus cannot fix to the abdominal wall through and through the to the other. Here you will appreciate the instrument comes to the translucent area on the right side and below that is the bladder which is being held by this flimsy layer. So once we cut this layer, the bladder would snap down and this whole space is created through and through and so there is no any vital structure remaining there and we can release the adhesions. So like it is being done and the bladder which is distended just to make sure where exactly I am to show you where exactly is the bladder. It's not necessary to fill the bladder always. Step 6 is the final step of releasing the uterus of its adhesion from abdominal wall. The incision is created due to the adhesiolysis. We pass one instrument from the right side to the left side into the free area and depress the cervix and the uterus downwards. So this gives us a direction into which we have to cut and also it safeguards the bladder. You know exactly how much abdominal wall. So now once you start releasing the uterus, at times you have these adhesions, glistening areas which are seen. So you can cut those areas. Now you have to exactly identify where is the myometrium and where is the glistening area facial of the abdominal wall. So here these are the tough fascias which we are cutting and you will appreciate the preperitoneal fat just above that. Release those adhesions. Here I am releasing the abdominal wall adhesion to the uterus. And if you are scared of cutting into the uterus and you go higher, you end up going into the anterior abdominal wall. And the dissection just keeps on happening. It's endless dissection into the space of Rexius. In these avascular spaces, you actually decrease your area of cutting, and it is under vision and with a lot of confidence. We have performed this technique in many cases, and then we have understood that this is duplicable and it is very, very easy to learn, very easy to identify. The surgery becomes bloodless. You don't have any distorted or any tissues which are stay abdominal wall in a very wide area. But as it involutes, the uterus becomes small and the adhesion area drops, it becomes thinner and thinner towards the abdominal wall, like a teardrop sign, where you have broader base, the uterus, and at the upper end you have this adhesion. So this adhesion has to be identified. When it is without any area dissected, you feel that the whole wide area is adherent. But once you create these paravesical spaces on both sides, you actually narrow down your area of adhesion, and then you actually identify the upper limit of the adhesion. So when you cut, you will appreciate that you are not having a uterus with a very wide raw area to send to the abdominal wall. Now this area is not the myometrium, it is the peritoneal, thickened peritoneal surface. And since we know exactly where is the fat, it is downwards, so the direction of incision would be towards that direction. So you don't end up going into the abdominal wall also. So it is a very, very perfect method of performing the surgeries. You get these patients, a lot of these patients are coming for secondary infertility where the uterus is adherent, the cervix is elongated, the cervix is not seen from per speculum examination, and it is difficult to perform the IUI, or you cannot just ask the patient to go to IVF just because she is not responding, because the IVF embryo transfer is also a very difficult task. So once you release this uterus, the cervix can come down, but at times you can even have small cervical area adhesion, which you have to identify in each case and then dissect that area as well. So appreciate the uterus is released, there is very small tag of tissue which is raw, and the rest of the avascular plane and area is dissected. So this is the standardized technique of adhesiolysis in case of a ventrofixed uterus. I hope you all take steps. Thank you so much for your patient listening. Hello friends. The incidence of cesarean section is on the rise.
Hello, Inam.
Yeah.
Okay, can you? You're mute. I cannot hear you.
What a wonderful surgery you did. It's I
Thank
know
you.
you are God gifted. Excellent surgery and very difficult surgery you did. This is very helpful for the fertility specialist because we are facing this problem. We face the problem like we difficult IUI. We face difficult embryo transfer. So I know what a beautiful surgery you did. So you can conclude your speech now.
Yeah, so I think that this unfortunate patients who land up with these adhesions, they can actually get this surgery done, and depending upon the tubal status, her age, her ovarian status, ovulation status, maybe the patient can be downgraded instead of an IVF, just because she has lost many years of her fertility and she's not conceiving. These patients can go back to natural intercourse, or at least the IUI and IVF, which becomes easy, and the embryo transfer is easy. So thank you very much for this wonderful opportunity. I hope I have also added to almost, like, we are very really enjoying the lectures from morning. So thank you for making me a
Thank you,
part of
thank
this
you so much.
excellent
Thank you,
academic
thank you,
IUI.
Sandesh. Thank you. Okay, thank you.
Yeah.